Here, we're going to review our endovascular management of an acute middle cerebral artery occlusion using mechanical thrombectomy and intracranial angioplasty. This is a unique case because rarely, or 10% of the time, there may be underlying atheroma. This is a 94-year-old female who was brought to the emergency room by her daughter after she was found down in the morning. She is awake, alert, and aphasic with a right facial palsy and right severe hemiparesis. Her NIH stroke score was 16. Her CT scan was normal, but CT angiography showed an MCA occlusion. Her CT perfusion showed increased time to peak and preserved volume at the left middle cerebral artery territory. She had a tortuous left common artery and an internal carotid artery. She was not a candidate for TPA. Here her CT perfusion shows increased time to peak, the red area, but preserved volume and flow. Her CT angiogram confirms an MCA occlusion at the M1 bifurcation. Given the tortuosity and the distal location of the lesion, we were going to use a triaxial system, getting access in the left internal carotid artery. Here we see the intermediate catheter being brought into the intracranial circulation, specifically into the distal ICA. The more tortuous a vessel is, the more critical it is to get distal access. The microcatheter is being advanced over a microwire, and the intermediate catheter is being advanced over the microcatheter. Here we can see the microwire and microcatheter in the M1 segment, and the microwire and microcatheter being used to lever the intermediate catheter also into the M1 segment. Under aspiration techniques, we use this reperfusion catheter to attempt to aspirate any thrombus. But you can see there's still occlusion at the M2-M1 bifurcation. Once we appreciate this, we cross this lesion with a microwire and microcatheter, attempting to get significantly distal access. This allows us for stability of the entire system. Again, we bring the reperfusion catheter near the area of the stenosis into the mid portion of the middle cerebral artery. And now we attempt a stentriver technique. Here we can be seen bringing up the retrievable stent through the microcatheter, which is inside the reperfusion catheter. We always attempt to deploy the retrievable stent in a normal segment of vessel distal to the occlusion and slowly unsheath the retrievable stent. We do not express this, as I may injure the vessel. Rather, we unsheath it from the microcatheter. We also want to be careful to move our reperfusion catheter proximally so we don't deploy the retrievable stent too far in the reperfusion catheter. Once we're pleased with the location of the retrievable stent and the reperfusion catheter, we use aspiration techniques in combination with the retrievable stent for recalcitrant occlusions. Here we can be seen slowly pulling the retrievable stent as not to disengage or dislodge the clot, but rather to trap the clot and hopefully remove the occlusion, allowing reperfusion. Again, we see a stenotic segment. While we have flow, we're concerned that this flow is not sustainable due to an underlying atheromatous plaque. Therefore, at this point, we're going to bring an angioplasty balloon an attempt to do submaximal angioplasty in hopes of creating sustainable reperfusion. We use submaximal angioplasty in order to avoid rupture of the vessel and to allow for sustainable reperfusion. Again, flow is proportional to radius to the fourth power, so even a modest increment in the radius of the vessel or the diameter of the lumen will allow for significant augmentation in flow.